It's 8:05. I think we can start. So good morning, everyone, and welcome to today's session of the Teledrama Grand Rounds. Thank you for joining us, even though it's Memorial Day and it's a holiday. So today we have Dr. Brittany Nowak, who is a surgery and critical care fellow at Jackson Memorial Hospital at Ryder Trauma Center, presenting a case. So over to you, Dr. Nowak, to start the presentation.
Thank you. Good morning, everyone. So today we'll be discussing a case of Dr. Ruiz and mine from a few months ago about penetrating neck trauma. It was a transcervical GSW. So arrival, patient was a 29-year-old male who sustained multiple gunshot wounds, notably to left zone 2 neck, and then 2 in the left posterior arm and shoulder, and then had several wounds on the right hand. His primary survey, he had agonal breathing and was promptly intubated. He was that one should be in the next part. He was hypotensive with diminished breath sounds, so we did place bilateral chest tubes. And then for circulation, he had an expanding neck hematoma that extended into the left chest. He also had some bleeding from the left arm wound, so a tourniquet was applied to the left arm. And he was hypotensive as mentioned, so he was transfused 2 units of PRBCs and 2 of FFP. Disability, his GCS was 3, but his pupils were equal, round, and reactive. And then an exposure, as noted in the prior screen, he had gunshot wound apertures to left zone 2 neck, and then had 2 in the posterior left arm, and then 3 wounds on the right hand. He was initially normocardic and normotensive, but then became tachycardic and hypotensive, which prompted the chest tubes and blood transfusion. And then we did obtain a chest x-ray that showed our chest tubes that were in place. The right side's a little bit kinked, but then these ballistic fragments in his right neck. So question for the audience, based on the clinical condition and the x-rays provided, what would be the next best management strategy?
Thank you, Dr. Nowak. Dr. Unchak, do you want to make your comments, please?
Certainly. So he's hypotensive and tachycardic, and I take it that there's nothing coming out of the chest tubes. Is that right?
Correct.
Yes. Okay. And then the reason for the hypotension is the neck wound, an expanded hematoma. It's a hard sign. My first step would be resuscitation. And how long after the gunshot are we now? After the injury?
I don't remember the exact timeline, but pretty soon after, maybe 30 minutes.
Okay. Right. So I go ahead and get some blood type O blood, massive transfusion protocols. Start with 2 units. And then prepare for the operating room while he's being resuscitated. Based on the chest x-ray, I can see the C-spine is not fractured. So it looks like what you have to, and it's good to have that early on, because if you see the fracture of the cervical spine of these wounds, and there have been several presented from U of M that have had that, the prognosis is very, very poor, because then there's usually a brainstem injury that's not survivable. This case doesn't seem to have that. So if the gunshot wound is anterolateral, and then they cross the midline, the 2 bullets, I'm thinking they probably went posterior, but didn't cause the spinal injury. So that's actually a good sign. And another question, was he moving his extremities when he came in? I guess no movement to pain. Glasgow Coma score of 3, so even to deep pain, he didn't make any movement. So,
yeah, not really.
Okay, so you don't know if he's, although even without a fracture, just a blast injury going by the spine can cause paraplegia. But at this stage, I would do the resuscitation with blood, and then hard signs of injury to the left neck, and take him to the OR for exploration through a long incision along the anterior border of the sternocleidomastoid.
Thank you, Dr. Unchak. Dr. Supa, would you make any comments?
I agree with Dr. Untrat to take this patient immediately to the operating room for neck exploration. And we should prep the patient from the neck down to the groin bilaterally, just in case we have to get in the chest for proximal control of the carotid artery or subclavian artery, and to get how to harvest the vein graft from the groins. And he needs to be in the operating room at this point. Thank you.
Dr. Supa, Dr. Frisbee, do you have any comments to add?
Can you hear me?
Yes, we can.
You can. Well, I can't add anything to it. I think they're doing the right thing. So far, so good.
Thank you, Dr. Frisbee. Okay, back to you, Dr. Nowak.
All right, so we did proceed to the operating room. Just given the size of the hematoma and that it was pretty rapidly expanding, it kind of had extended into the chest wall. We had planned to start with a sternotomy just to get isolation of the great vessels off of the aorta. But then after induction of anesthesia, the patient was hypotensive to systolics of 40s. So then the question was how to proceed there. And of note, we were having issues with our sternotomy saw as well.
Mhm.
Dr. Frisbee, do you want to make your comments first?
Well, if you're having trouble with your saw, sit over in the corner. There is a knife you can use. It's called a Lepsky knife. And if you got a nice strong right arm and a hammer, you can get through the sternum in about 5 seconds. However, the hypotension worries the hell out of me. If he's been inducted and he automatically has become hypotensive, you're going to have to tie something off, and I don't know what it is yet. We haven't gotten down to it. That's all I can tell you.
Thank you, Dr. Frisbee. Dr. Supa, do you have any comments?
In this situation, I think we have to dive in the chest quickly. I would start with the left thoracolateral, left anterolateral resuscitative thoracotomy, and extend quickly to the right to make it a clamshell thoracotomy. With this incision, you can expose everything in the chest. You can do any resuscitative maneuver need to be done in the chest. You can relieve the tamponade. You can internal massage the heart, and you can expose the mediastinal vessel, and you can do the proper proximal control of our vessels. So I would start with left thoracotomy, extending to the right to make it a clamshell. Thank you.
Thank you, Dr. Supa. Dr. Untrat, do you have any comments?
Yeah, so the thing about the median sternotomy, this is an injury in the left neck, and the median sternotomy is ideal for injuries to the right neck because you can easily access the innominate artery off the beginning of the aortic arch. And in this case, though, if the patient, as Dr. Supa mentioned, is fully prepped, I would go ahead and make an incision in the neck and rapidly get control by direct pressure, putting a hand in and then directly finding out what's bleeding, putting a finger on it, suctioning, and then if you need to get proximal control, depending on what it is, if it's either the carotid or the subclavian, that's probably in this case best done through the left chest, especially if it's the left subclavian. You wouldn't really be able to access that through through a median sternotomy, and the carotid, possibly the left carotid, but in a young person, if it's the common carotid that's bleeding, you can treat that by ligating both sides. Just ligate the carotid on both sides, and that's an adequate, acceptable treatment, especially in this case for dealing with an open wound of the common carotid artery, because especially in a young person, it'll be perfused across the face from the external carotid on the right side through the external carotid on the left, retrograde, and then up the internal carotid. So that would be my approach here. Get into the neck, get controlled manually, and the resuscitation should be ongoing. I don't know how much blood he's received now, but he needs to be volume resuscitated. And he's really not bleeding from anywhere else except in the neck. So I would focus there.
Thank you, Dr. Antrak. I see that Dr. Ruiz is here. Do you like to make any comments or add anything, Dr. Ruiz?
Yeah, well, this is my case actually, so I'm not gonna give up too much spoilers, but the whole case is about trying to anticipate to the next step. Things like communication with the OR on the equipment that you need, and the situation kind of changes and it's very fluid. So even though your plans have to change every 2 or 3 minutes because the patient conditions change, the whole idea is to try to be ahead of the game, trying to not be reactive to what the patient is doing, but actually to be proactive and try to, you know, catch the patient's deterioration before it happens. So you will hear the rest of the case. I'm not gonna give up too much spoilers here. Go ahead.
Thank you, Dr. Ruiz. Back to you, Dr. Nowak.
All right, so we did start with an anterolateral thoracotomy. There was no blood within the chest. We opened up the pericardium. There was no blood within the pericardium. And kind of as we were doing this, the hemodynamics improved. So the aorta was not cross-clamped. So essentially negative thoracotomy there. And perhaps it was just an over-aggressive induction of anesthesia, or that we were a bit behind on resuscitation. So then next in the OR, we proceeded with our median sternotomy. We identified the great vessels coming off the arch of the aorta and vessel loops around each of them. And then we ended up clamping the left subclavian just off the aorta, anticipating potential bleeding. After that, we then proceeded with our left neck exploration. Since that was kind of the majority of the hematoma was in the left neck, expanding to the left chest. We did see hematoma within zones 1 and 2. We opened up the carotid sheath. There was no injury noted there. But then we did find that the left IJ was transected from the bullet, and then that transection kind of extended into where the left subclavian vein joined. And so both of those were ligated proximally and distally. But then after the bleeding was controlled, we noticed that the trajectory was kind of more posterior through the posterior trachea. So I was just hoping to open it up things to discuss repair of tracheal injuries. This one was pretty massively destructive and posterior, you know, it wasn't like a straightforward stab wound to the anterior neck where you can just put a couple sutures in it.
Thank you, Dr. Nowak. Dr. Supa, would you like to make your comments first?
I think repairing the trachea in this situation would be difficult. And the patient is not quite stable at this point. And but what I'm going to do about this, I'm going to try to check for any esophageal injury behind the trachea, because it's common to have both organs injured at the same time with this type of mechanism. And if there's no esophageal injury that needs repair, I would just take a note on the injury, and maybe we can deal with that later, because we have the tube distally to the distal trachea, so we don't have problem with airway and ventilation. To repair this, definitely after the patient is stabilized, we can call our cardiac surgeon colleague to help. And sometimes I have seen them using the bovine pericardial patch to bridge the defect. But now we should be okay, because we have the tube that went in distally to the injury point. Thank you very much.
Thank you, Dr. Supa. Dr. Antrak, would you like to make any comments?
Yeah, yes, I agree with Dr. Super. You don't have to do anything aggressive now. And I would, you know, as Dr. Super said, a full exploration of the neck, look for if the posterior trachea is injured, I presume you mean the membranous portion is injured. So there should be an injury of either the hypopharynx or the esophagus, and I would do at this point damage control and leave drains if you have a injury to the esophagus. You can try to repair it, or the quickest thing, either put some sutures, leave a drain, exteriorize it as a spit fistula, as a loop, bring the injured portion out onto the skin, if you can do that quickly. But I wouldn't spend too much time, and then just the final option would be just leave drains, leave the tube in place. You can leave the wound packed open, and then let the patient recover, because you're ahead of the stage. If I can just ask, how long was the injury, and what did it involve? The cartilage destruction? Was it total division of the trachea, or just a length of membranous portion?
It was a good portion of the membranous. It was hard to visualize because it was the posterior part, but you could just kind of feel behind that your fingers on the ET tube. And it was the membranous portion mostly, and then a little bit of the posterior cricoid cartilage.
Okay, so the high trachea, and about how long? Was it 3 centimeters, just 2 finger breaths, or longer than that? Or
I would say something around that size, yeah.
Yeah, and that's something I wouldn't really try to do anything definitive now, because there are experts that do nothing but operate on the trachea. So that this would be a case for them when and if, and hopefully if the patient recovers. So I agree with Dr. Supa in this case.
Thank you, Dr. Antrag. Dr. Frisbee, do you have any comments to add?
Yeah, I would. Suprick is absolutely right. When the trachea is injured, the esophagus most likely is injured also. And if you let that one get by you, you'll have a bad day. So I would really be circumspect about looking for an injury to the esophagus. The other thing is, I thoroughly agree with everybody. These things, once he's stable, can be dealt with, but you don't want to miss an injury here. You want to be able to categorize it. But all I can say is, where's Hermes Grillo when you need him?
Exactly. My mentor, I was thinking of him when I spoke.
So he's the number one guy. Unfortunately, he's gone, but he was the number one man in the study of how to treat the injuries to the trachea. But he's not here any longer, so I'm sure we've got somebody up there or down there that can really go to town with this one. But he needs to be stabilized at this point. That's all.
His successor is Douglas Mathieson, who's up there.
That's all I got.
Thank you, Dr. Frisbee. Back to you, Dr. Nowak.
So that was our left neck exploration. And then since the bullets were lodged in the right neck, we proceeded with the right neck exploration. We didn't note any vascular injuries, but we did find the esophagus on the right neck and encircled it with a Penrose. Again, we noted the massively destructive posterior tracheal injury involving the cricoid cartilage. And this we actually did repair during the index operation. It's not a perfect picture, ignore the jejunal flap part. But we repaired with the SCM flap. Just the sternal head of the SCM, took that off at the sternum and then passed it posterior to the trachea, and then sutured that to the strap muscles on the other side. And then, like everyone had said, we were highly concerned about an esophageal injury. We didn't see it. The patient didn't have an NG tube or an OG tube in place yet. So then we asked anesthesia to pass an OG tube, and we did note a small esophageal injury that was repaired with the running PDS in one layer. And then we covered that up with the muscle flap as well. And then obviously they left a drain there. So kind of like everyone said, we ended closure. And then another question for the audience, kind of given his injuries, would you perform a tracheostomy on this patient? And if so, would you do this during the index case? do it in a delayed fashion because he kind of has a lot of incisions on his neck at this point, and including the sternotomy, not much, I guess, territory to place our trach.
Thank you, Dr. Nowak. Dr. Untrack, would you like to make your comments first?
Yeah, well, you don't have to do it now. He probably will need some more advanced management of the airway given the tracheal injury. And, you have options that I probably wouldn't do it now because you can leave the tube in, your low pressure cuff tube, leave it in for, in this case, probably an extended time, because the reason to do a tracheotomy is to avoid tracheomalacia, injury to the trachea, which is already injured. So, it's, and then the balloon I can see on the original chest X-rays inflated in the well below the area of the injury. So I probably wouldn't do it now, given that you have incisions in the neck and then right in the, up to the probably to the manubrium, and and then if need be, you can possibly consider doing it percutaneously later. But I think you're gonna wind up consulting a tracheal surgeon anyway to follow him and see how he does. So I in this case, I probably wouldn't do it. I would defer.
Thank you, Dr. Untrack. Dr. Supa, would you like to make your comments?
I agree with Dr. Untrat. Thank you.
Thank you, Dr. Supa. Dr. Frisbee, would you like to add anything?
Yeah, I agree with Stephen. Why poke the bear? You got plenty of time, and just let him recover.
Thank you, Dr. Frisbee. Back to you, Dr. Nowak.
So just kind of completion of the OR, the wounds were packed and temporary closed with skin only closure, and then he was taken for CT. The blood products he received during this case was 14 PRBCs, 13 FFP, 2 platelets, 1 cryo. This was a picture from our case. It's kind of hard to tell what's going on in it, but I was told to put a picture. But I think we have our esophagus looped over there, our sternotomy. I think this might have been around our venous injuries over here, but it's kind of a mess. The post-op CT scan, nothing particularly exciting on there. You can see the ligation of our left IJ and subclavian vein. All of the neck vessels are a little bit diminutive. Bilateral carotid vertebral, left upper extremity arteries were patent, but with diminutive caliber. I didn't go into the arm stuff, but he ended up having good pulses in the arm with the tourniquet off and wasn't actively bleeding from the arm anymore from those 2 apertures there. And then they read like a possible TBI and some pulmonary contusions, and then some possible venous bleeding in the left arm. But again, there was good runoff there. So then taking him back to the OR, post-injury day 2, we ended up taking him back to the OR to remove the packs, and then formally closed the bilateral neck incisions over drains, our sternotomy and thoracotomy over chest tubes as well. The trachea, the repair was interrogated. We let the ET tube balloon down, put some saline in there, and performed a Valsalva to try to see if any bubbles would come up, but we didn't see any there. And then his post-operative course, and we had hoped to try to extubate him early just to minimize, the time that a tube would be there next to our injury. But of course, he got ARDS and required vent support and paralytic in the ICU. He did end up weaning down to vent settings coming off the paralytic and was on appropriate settings for extubation. So he was extubated post-injury day 20, but had some stridor and required re-intubation pretty quickly after that. It was just kind of a trial. We had been planning, like you guys had discussed, to do a trach after the skin incisions and everything had been allowed to heal for a little bit. So it ended up being on post-injury day 21 that we did a percutaneous trach. He had pretty good external landmarks, and just to minimize the dissection in our operative field, we started percutaneously and were successful with that. Oops, sorry. And then the gastrostomy tube placement, he had had a prior laparotomy for trauma, and there wasn't any good window on his CT scan for PEG, so we ended up just doing an open gastrostomy tube. He was subsequently weaned from the ventilator, and then we got our ENT specialists in there. And they evaluated the patient and they noted subglottic stenosis as well as left vocal cord paralysis. He was ultimately evaluated by speech and cleared for a PO diet as well. His tracheostomy was downsized to an uncuffed trach. His drains were removed also. I forgot to put that in there. Chest tubes and drains were removed. And then he was discharged home from the hospital about 5.5 weeks after injury. At that time, he had an uncuffed trach in place and was on a PO diet. He was seen in our clinic later. We were able to get the gastrostomy tube out. He was taking everything PO. And then I haven't seen a note saying that he's been decannulated yet, but he's been tolerating trach capping trials and was following with ENT for potential decannulation. That's kind of all I have for this case. I don't know if anyone has any additional comments or questions or anything for me.
Thank you, Dr. Nowak. Dr. Supa, would you like to make your final comments?
Thank you, Dr. Nowak, for presenting this interesting case. And this is the great save. And I think you and Gabe did the very good job to this patient. And he is very lucky to see you guys. Thank you very much.
Thank you, Dr. Supa. Dr. Anjak, do you have any comments?
Yeah, so well done. Nice case. And it looks like in this situation, the bullet went across the tracheoesophageal groove on the left side, took out the left recurrent laryngeal nerve. So you didn't do it, the assailant did it. So you got somebody to blame it on. And then I think his laparotomy, was it for a gunshot wound or a blunt trauma or what?
I think it was something penetrating. I don't remember exactly, but
yeah, I just bad luck from the wrong part of Miami. I guess it'd be better to avoid these things to begin with. Start with the root causes. But anyway, and then the subglottic stenosis. The ENT person, what is his feeling that he may need to do a procedure, or he'll manage without any further operations for that?
the notes weren't particularly verbose, but it seems like just kind of managing without it was my impression from what they were saying.
What Dr. Grillo used to do, he was the master in this, just excise the stenosis and do a primary anastomosis, and sometimes usually wrap it with omentum, wrap the repair with omentum. Pretty straightforward, but something that very few surgeons actually do, and maybe today the ENT surgeons are doing that. But very, very well managed, a very good management of the tracheal injury.
Thank you, Dr. Anjak. Dr. Frisbee, do you have any final comments?
Yeah, very, very good case. Tracheal injuries are highly specific, meaning that you need a highly specified surgeon to do those, because, we don't normally out of the, except once in a blue moon, see these things. And it's always good to have a case where you can refer back to. Grillo, when he was repairing these things, sometimes didn't have enough length. He'd release the inferior pulmonary ligament. This is something that I'm not going to do, but it's a very, very, very good case. The idea that this gentleman has had a previous laparotomy for trauma speaks to the idea that he's a veteran. He can take it. So you did a great job, and you should pat yourself on the back for it. That's all I've got.
Thank you, Dr. Frisbee. Dr. Ruiz, would you like to make any comments?
Hello. Yeah. So all the points are very valid. Damage control in the neck is it's something that you have to apply and think about every single time. In this specific case, once the IJ was vacated, the patient stabilized. But the main issue there was, to me, the fact that the patient had also an esophageal injury. So there are two options there. The patient's physiology is good enough that the patient would tolerate, half an hour more of surgery. Then, in my opinion, it's better to do the repair right there before all the inflammation sets in. If you cannot do it, which could happen, the patient may continue very sick. Then you have to be sure that you drain very well this area. because once the mediastinitis and all the infection sets in, it's impossible to put any sutures. It's impossible to do a better repair. In this specific case, the patient stabilized. We kind of took a little bit of a break there, discussed what we were gonna do. And the other thing is the location. We got lucky here because the location was very far away from the balloon of the tube, so we were able to keep ventilation while we were doing this. In those injuries that are close to the balloon of the endotracheal tube or that are distal, they're usually fatal or very difficult to manage, and then you need ECMO and things get really complicated. The location of the injury, very high. Discussing these after the fact with the ENT people for them to do this type of reconstructions is very involved if you are resecting the injury and trying to repair it, because it's very high. It's in an area in which both the esophagus and the trachea kind of share a common channel, just divided by a membranous portion, which is what was blown out by the bullet. So these repairs, when you take down the entire trachea, they're very difficult. They're very morbid. And then the last thing, I did have the chance to talk to the ENT surgeon maybe 2 or 3 weeks into the patient's recovery. And their plan is to continue managing this without any procedures and operations. And if the patient has significant stenosis, then they may dilate, do dilation, serial dilations of the subclavian area. And then the damage of the recurrent laryngeal nerve. I think Dr. Nowak maybe can tell me. I think we documented this in the initial operation where we saw where the damage was coming from the bullet. So all in all, in a case that's a hard case that really tests the system, because you need a lot of stuff. You need to get into the chest. You need to get into the neck. You're thinking about putting shunts and asking for equipment. And if you don't have a well-oiled trauma system, it gets sometimes difficult. And then we got lucky because the injury was pretty high, and because the two organs were in proximity, the esophagus and the trachea, just by passing this flap of muscles underneath and around the esophagus, we were able to accomplish the repair. Thank you to Dr. Nowak. Excellent presentation. And thank you for all the audience coming and see it. Excellent discussion.
Thank you, Dr. Ruiz. I think that's all we have for today. So unfortunately, I don't have the CME code, but I will email you all with the code. The CME office did not send it to me yet, but I will email you all with the code by tomorrow, if that's okay. I think they
I think we have 24 hours. Is that right? 24 hours from now. Is that right? To put the code in?
Oh, is that how it works? Okay, I will email you all with the code by the end of today.
Oh, okay.
Thank you.
I think it's because the CME office is closed. I don't know. I think it's Memorial Day, but
Nah,
I'll call
You
them.
think so?
All right.
I reminded them this morning again, but they haven't sent it to me yet. But I'll email you all by the end of today.
Yeah, go down on South Beach and get that guy. I'm sure he's laying out there.
Okay,
Thanks very
you
much,
all.
Maya.
Thank you, everyone.
Oh, yeah.
You're welcome.
Bye.
Well done.
Well done.